Um, Hello, everybody. It is a great pleasure to introduce Dr. Dangus, who's a professor of medicine and surgery at Mount Sinai, New York. A lot of you know him. If I went through his entire CV, I could probably take up the whole hour. But congratulations for MACC of last year. Dr. Dangus, we are so proud of you. That is such an honor. And also being the president-elect of SCI. The other very interesting thing about him is he's the director of cardiovascular interventions, especially in the field of endovascular therapies, as well as all the interventionals within the interventional space. He is going to talk to us about the TAVR leaflet thrombosis post-TAVR pharmacotherapy. I think this is going to be extremely interesting, mostly because we have such conflicting data. So I'm really looking forward to listening to what he's going to teach us. Dr. Dangus?
Well, thank you very much for this warm introduction. It's a pleasure to be discussing this topic with the faculty of Robert Wood Johnson. I know several of you, and I've heard many more as well. And definitely one of my close friends and collaborators at Mount Sinai here, Dr. Partho Sengupta, is leading the program there, and that's great. We're going to talk about TAVR leaflet thrombosis and what this field meant and means about TAVR pharmacological therapy. PPI of the studies and relevant grant has been given towards Mount Sinai, as I will explain anyhow during my presentation. 20 years of TAVI was just almost yesterday, and you can see the very first patient, obviously with many more comorbidities, and ultimately clinically, after a few weeks, things didn't go very well due to the non-cardiac illnesses. Nonetheless, was a hero because allowed another hero, Professor Cribier, to show that it is possible to treat a human being with this type of device, a stent-mounted bioprosthetic aortic valve. A lot of this happened, and many more hero patients in the initial studies, many papers. And at the same time, several complications came about. And we talk about the complications after TAVI, or TAVR if you want, as we call it in the United States. TAVI is for the rest of the world. It's a bleeding or ischemic events clearly dominated for the procedure time to begin with. Because a large sheath is going in, hemostasis is of concern, vascular complications could propagate bleeding. At the same time, large bore catheters are handled around the aortic arch, the aortic valve, the great vessels, and they as well produce some emboli in patients who are already prone to have atherothrombotic disease of the ascending aorta and the arch, the great vessels anyhow, as well as in a population who's elderly and with risks or even established atrial fibrillation. And you can see that in the beginning, there is, after the procedure, the early period after the procedure have accentuated these risks, and over time, we hope to mitigate them. But ultimately, our patients will grow older and will develop other reasons and risks for this type of adverse events. So when we talk about increased platelet activation in prothrombotic patients, we're talking about the factors, the bioprosthesis, the suboptimal understanding or effect of antiplatelet agents, morphological alterations, and hyperactive response of platelets, as well as, very importantly, at the top of my panel here, the disturbed aortic blood flow with the transvalvular gradients, the shear stress, and the related endothelial injury. All of those things have I would say, a dynamic situation around the aortic valve region. Now, if we want to simplify all that, we can say, well, we can have valve factors and patient factors. We can do something about the valve factors, perhaps, during the procedure. We can do something about patient-related factors through other means we know anyhow, from coronary or peripheral arterial disease. And in the end of the day, when you're talking about preventing thrombotic events and strokes, for example, we're talking about antiplatelet or anticoagulant and how we mix and match them. Well, it may be what we're going to be discussing about. The main unknown is that thrombosis, and from the get-go, is a thrombosis during and after a valve procedure or a valve procedure mediated mostly by platelets or by thrombin. And that's, if the process is mediated by platelets, it'd be logical to prefer the antiplatelet agents. If it's by thrombin, perhaps we need anticoagulants, or maybe perhaps we need a combination of both. And how about if other aspects coexist, such as coronary disease and angioplasty, or carotid disease, perhaps stents or endarterectomy or atrial fibrillation, then what? So then we understood that number 5, that we have a variety of ongoing studies about ongoing situation or existing complex situations that can happen or adjunctive pharmacotherapy should actually, dominate the field, but at the same time we have a lot of uncertainty. One of the first things, even the original TAVR studies indicated, there was something going on with strokes. And if we're going to think about where strokes come from, well, they may come from aortic arch atheroma, new onset atrial fibrillation or pre-existing atrial fibrillation, or the valve itself. These are the 3 possibilities. And imagine where else would they come from. The predictors of cardiovascular events after TAVR from early studies indicated that new onset atrial fibrillation was a dominant factor. And of course, the questions came about then, is it new onset or is it newly diagnosed, previously silent or undiagnosed or unnoticed atrial fibrillation? At the same time, we have issues of chronic kidney disease, as well as technique and, let's say, learning curve aspects are important in the rate of strokes. Valve hemodynamics came out as I would say, a weak factor about if anticoagulation therapy can actually produce or be helped by after the valve procedure. It really didn't seem to make a tremendously big difference, if at all. Subclinical thrombosis was all of a sudden noticed as a new and alarming event. Why new? Because we couldn't see it before. And why alarming? Because nobody likes it. If anybody around our family or even our colleagues or even all of us in this session today are asked, would you mind, or your patient has a little clot on the aortic valve, would you mind that? I don't think there's going to be anyone who's going to say, yeah, sure, I don't mind, I don't care, let the clot happen on the aortic valve. It's just a location and the statement that makes us uncomfortable about it. And the revolution in imaging was really what made about this previously unnoticed entity. So you can see here in those dynamic CT scans, and what is a new imaging? Many people don't quite understand. The CAT scan always existed, the CT angiography always existed. So what is this new imaging? The new imaging is a dynamic CT angio over time that you can actually create, as I like to call, I'm not sure why other people don't show it, don't call it like that, a CTA video. It's not just a CTA, it's a CTA video. So you can see the entire cycle, how the valve opens and closes. And then it's rather apparent, if you have all this powerful technology, to actually notice that some of the leaflets, or any of the leaflets, maybe one of the leaflets, don't really close very well. And if the top row is a little ambiguous to you, because that's a static picture, the more 3D reconstructed image in different types of diastole and systole make very clear which leaflet is the immobile or the relatively immobile one. So that's a stunning capacity that we all of a sudden had with this new, very powerful imaging technology. And then went ahead and imaged all sorts of valves. And we found out that this wasn't like something one valve had, or perhaps one might say one bad valve had. Any valve, any type of valve could have something like that, inclusive of the valves implanted by surgical techniques. So why is it new? Again, it's new because we just see it right now. Before, we just couldn't see it. If you don't see it, you can't study it. So we knew because we were just surprised to see it. This even ended up that the FDA mandating imaging sub-studies in the ongoing low-risk TAVR trials and indicated that the systematic CT scanning should be incorporated as part of whoever, of a smaller number of patients, of course, but it has to be offered as an imaging sub-study in order to really understand what's happening there. And what we found happening was that there was a lot of leaflet clots. You can see there was between, initially, one can say, look at 30 days. There's 13% with a TAVI and 5% with surgery. That's pretty good. But hold on, look at 1 year. All of a sudden, we're talking 28% with TAVI and 20% with surgery. So one can say, okay, whatever, that's a TAVI problem, don't worry about it at 1 month. And later on, you can say, hold on, this is nearly 1 in 4 patients affected by that, no matter what. Let's take it a bit more seriously. Interestingly, the mean gradients did not seem to be affected. And that was, I would say, a blow against the practicality of detecting this. Because the simplest method that we evaluate the patients after aortic valve replacement is a transthoracic echo. If the gradient is not affected, all of a sudden we're talking about to find this interesting, fundamental, concerning imaging complication, we really need only advanced imaging. The classic, simple way everybody could follow, it just doesn't work. In the evolute low risk, the other valve, again, very similar aspects were found. And then we went on and said, you know what? Let's see how things can be restored. If it's clot, maybe we can just dissolve it. And if there were normal leaflets, they got a little clot and they stopped moving, well, I can dissolve the clot and then they may move again. That was an interesting idea, an interesting aspect. After several years, and I would say an international consensus that we worked out with in the Galileo study, we have the very, very clear classification of this phenomenon that you see here. On the top, you can see the CT imaging, and on the bottom, you can see a schematic that you can understand a little bit easier. The more the cup fills with this dark blue stuff, which is clot, the more it can open. It's like a door stopper that just doesn't, it's small, it's tiny compared to the door, but it just doesn't like let the door fully open. That's how this works. Now, restoration of leaflet motion without anticoagulant therapy in a retrospective fashion wasn't able to be documented. So if you just let it be, it wasn't going away. And again, this is now imaging that is not a routine imaging in these initial studies. It was imaging because it was clinically driven. Therefore, it was imaging that had a lot of volume of this clot. That's why it was causing a lot of disturbance. Interestingly, when we deal with these patients, you have to counterbalance. And now we know that thromboembolic events, just as much as bleeding, have a lot to do with mortality. That's a very simple slide. We didn't have any idea about that. We don't have any grasp about that. I might have thought about it, but we really hadn't documented that. We knew that bleeding after TAVR is important, and mortality is also important. Bleeding, I should say, is important for mortality. And when we talk about bleeding, both the early bleeding as well as the late bleeding is important for mortality. This is a sub-analysis of the partner trial. Interestingly, when we went into the partner trials that everybody knows about, we found that these trials didn't have a very detailed bleeding documentation, definition, and analysis. They were mostly limited to the periprocedural bleeding, and everything else was reported, I would say, in a little bit more relaxed manner. Interesting and astonishing if you look at it from today's knowledge, on to the time that these studies were designed, I mean, nearly 20 years ago. That wasn't thought to be a significant endpoint as much as it is today. Now, the time after TAVR with thrombotic and bleeding events, this is the time to death, is very important because the time to death at a thromboembolic event seems to be much accelerated than after the bleeding event. But this doesn't mean that the bleeding is less important than the thromboembolic event. Ultimately, we had to counterbalance thrombotic and bleeding risks. And that's what the initial guidelines tried to do in some ways. First of all, there had to be some guideline. Everything was being accelerated, and these procedures were becoming popular, and people needed to know what to do. So based on our knowledge from coronary disease and coronary stents, after all, these valves were stent-mounted, a dual antiplatelet therapy recommendation was developed by consensus documentation. Later on, this was simplified by the ESC and a little bit less simplified in the American guidelines. All the studies in anticoagulation were rather small. This is one of the biggest studies and has 110 patients per group. In my agenda, this is a glorified pilot study. It did show that the addition of clopidogrel, inclusive of a loading dose, didn't make much of a difference, and if anything, might have caused some bleeding in the patients. Clearly, it hinted or suggested, but it really didn't prove anything. So in the Galileo study, we tried to take patients that would otherwise be treated with antiplatelets, and so therefore those who didn't have atrial fibrillation. And we randomized them to an interesting combination therapy for the initial part, rivaroxaban, very low dose, 10 milligram, which is a venous thromboprophylaxis dose, nothing to do with a 15 or 20 milligram of the atrial fibrillation conditions. And then after 3 months, the groups were continued on monotherapy, rivaroxaban versus baby aspirin. Interestingly, we're surprised both ways. First of all, the expected outcome was a trend towards higher bleeding in the rivaroxaban arm. That's on the right side. In many ways, that was expected. Indeed, we're expecting would be trend and not highly significant. What nobody expected was that the overall MACE, the composite of death, stroke, MI, valve thrombosis, DVT, or systemic embolism, driven mostly by all-cause mortality, would be higher in rivaroxaban, particularly in depth of time. We're also surprised by the fact that even the small dose of rivaroxaban was highly important in reducing the leaflet clotting. I think very few people were expected the adverse event on the mortality, and equally very few people were suspecting the great effect in preventing leaflet clot. So all of a sudden we had a disparity. The valves were being cleaned up, but the patients weren't doing so well longer term. Then we had the European, at the same time really, we had the European investigators trying to configure the situation of clopidogrel in two populations, those without or those with an indication for chronic oral anticoagulation. So all the patients received all drugs before the procedure. So it wasn't really a post-procedure study. Actually, thus far, only Galileo was a pure post-procedure study. The ARTE and the Popular study, and most other trials actually, they were studying the medicines before. So they were muddying whatever happens during the procedure or bleeding during the procedure with what we should recommend or not upon patient discharge. And you can see, for example, here that the clopidogrel in this population adds a lot of bleeding early on. That you can see that on your left hand side. But after discharge, looks like both lines are completely parallel. So it looks like the clopidogrel has a risk early on related perhaps to the loading dose, most likely. But after the discharge, it doesn't really seem to add much of a bleeding risk, actually none, if we believe this study. Interestingly, on the right side, you can see that the aspirin group, the monotherapy group, perhaps by averting intense antiplatelet early on, allows a updrift of events throughout the entire first year. That's an interesting finding, and we can see if any other study can later on, hasn't been done yet, may investigate this a bit further. As far as the anticoagulation, and again, this was the only study that started everyone on oral anticoagulants before the procedure as a routine. There was a lot of bleeding. You can see on day one on the left side, 10% versus 20% of major bleed. If my patients had a 10 or 20% of major bleed, I'll be very unhappy. And again, why is that? In this study, they started patients on non-reversible oral anticoagulants from a get-go pre-procedure. Nonetheless, they did show that clopidogrel had a lot of noise early on, up to 3 months particularly, and therefore it doesn't seem to make much sense, particularly if you look on the right side, and you can also verify that clopidogrel, as indicated here, had a lot of increased MACE as well. Then we had a study just like Galileo in on one arm and just like Post-TAVR on the other. What do I mean by that? They had two strata, one with, one without indication for oral anticoagulation, and they gave to everybody the full dose of apixaban. That's a difference between this and Galileo. We utilize low dose rivaroxaban. They utilize, the French investigators utilize full dose apixaban. And we have two kinds of outcomes, two kinds of populations. One is the patients who had no primary endpoint inclusive of death, stroke, MI, systemic emboli, intracardiac thrombosis, or major bleeding. And you can see that the apixaban was slightly lower, but non-significant. Then, if you investigate patients who did not have the CT scan evident of valve thrombosis, again, a similar event, similar p-value, one can say, similar comparison, non-significant difference, and the apixaban now was just slightly more events. But what I find interesting in this study, if you look at the strata separately, in the relatively smaller stratum that had oral anticoagulation, apixaban was versus Coumadin here, pretty much, and just about 200 patients per group, not a very big study. We can see that not a lot of difference between the two, but somehow there were a few more valve thrombosis for the standard of care. When, however, we go to the no indication for oral anticoagulation, we have many more thrombosis in the standard of care, which is antiplatelet therapy. But how, on the other hand, we have a pretty much of a repetition of the Galileo findings with higher mortality and higher cardiovascular mortality, as well as specifically non-cardiovascular mortality in the long term with apixaban. So what we first described in Galileo in patients without oral anticoagulation was verified once again with a different agent, albeit with higher dose as well, that the intensity of anticoagulation doesn't seem to be the problem, but may be that somehow in the valve patients, this type of drugs have an adverse longer-term outcomes when they're not absolutely needed, meaning in this population that didn't have an indication for oral anticoagulation. In the sub-study of a CT angiogram, the Atlantis investigators had a dual finding. Overall, the result was negative, no difference. Why? Because there was no indication for oral anticoagulation. There was a clear win for apixaban, less clot compared to antiplatelet. However, there was somehow more clot in the CT scan imaging of the patients with apixaban versus coumadin in the study, and that's why things overall didn't pan out as planned. But in general, in the patient with no anticoagulation, it indicated that no indication for anticoagulation. The apixaban again showed that was able to prevent the clots as compared to antiplatelet therapy. The interesting slide of this study is that it showed that in the short term, 1 year, nothing much will happen of these clots in the valve. This in the red line are people who had some clot, actually significant clot, class 3 or 4, cup semi-full or nearly full, and those who didn't have that. And they didn't seem to have much difference in the outcomes as far as the clinical overt outcomes. So although there's a clot, there's a small clot perhaps in the valve, this clot doesn't seem to fly towards the brain too often. That's a good thing. So it wasn't associated with a stroke or other deathly events. Then we go into envisage TAVI-AF trial, and we had in this population 100% atrial fibrillation indication for anticoagulation. We compared edoxaban to vitamin K. We allowed antiplatelet therapy, particularly if patients were implanted a coronary stent. It was about half of the patients were selected for this type of therapy. And we had the classic vitamin K antagonist level, RNR 2 to 3. And the edoxaban had some very, very important dose reduction criteria per the package insert in relation to body weight and creatinine clearance for the most part, plus some rare medications that nearly nobody had in our study. Interestingly, the study met its primary endpoint and indicated the non-inferiority as far as death or MACE, as you see on the left side. On the other hand, on the right side, we found some safety concern regarding major bleeding, particularly as the lines indicate beyond 1 year of follow-up. These are the ischemic stroke and all-cause death that, if anything, had a more favorable profile than expected from what I just showed you before in the MACE and NACE criteria. So at this point, I think we jumped on one slide. There's limited evidence available regarding the choice of optimal antithrombotic therapy after TAVI. Based on the recent data from a series of trials, even a low dose of anticoagulation is effective against the CTA-driven diagnosis of TAVI leaflet thrombosis. When another indication of oral anticoagulation exists, monotherapy is the most reasonable option. There is no role for routine oral anticoagulation, either as full or intermediate dose, when no clear indication for this exists. The up to now widespread clopidogrel loading before TAVI is no longer required. A prolonged combination of thrombotic strategy should be avoided if there is no indication of both antiplatelet and anticoagulant therapies verified at every visit. A tailored approach is mandatory, therefore, especially in light of the high burden of comorbidities of patients with undergoing TAVI. The valve durability and the impact of leaflet thrombosis and the various antithrombotic regimens are still an unexplored arena, and we don't have much to say about that, except that more studies are required to develop a rational and customized strategic approach and to understand better the valve-related events as well as the valve durability aspects in this field of medicine. Thank you so much for your attention, and maybe we can spend some time addressing some questions around this very interesting topic.
Dr. Dangas, thank you so much for that wonderful presentation. Hearing from a leader in the field is exactly what we needed to do. There, I can potentially start off with a couple of questions. You very eloquently described everything, kind of what took us through all of the recent studies. The incidence, obviously, of halt or even thromboembolic events is pretty vast when you look at these studies. It ranges from 15 to 40%. Is it likely because they're just looking some at the acute, some at subacute, some at chronic, or is it just recurrent events that you see?
Yeah, well, interestingly, the field initially was dominated by registries. Because of an alarming event, everybody started tracking or reporting what they see. And they employed different definitions, not so standardized, and essentially was also had a flavor of the reporting the more severe events. Why? Because in the clinical practice, the subtle events, they really, go unnoticed. When a systematic evaluation was mandated by the FDA, you see by 1 year, clot was detected between 20 and 30% of patients. This is a staggering combination. It's a staggering statistic. What it also showed, and I didn't want to go too much into the detail, it did show that it wasn't the same patients. When I show you it was between 10 and 15, or between 5 and 12 in the 3 months, at 1 month, and between 20 and 30 at 1 year, many people might presume that the same people who had it at 1 month had it at 1 year, plus some more in order to make up the bigger percentage. Well, actually, that wasn't the case. Some people, about half the people who had it at 1 month, well, they no longer had it at 1 year. And there's some people who didn't have it at 1 month, they did have it at 1 year. So not only is it variable between the valves, but it's also fluctuating. Even if you don't do anything, none of the studies at the FDA mandated to track, if you want to document this phenomenon in low-risk patients, none of them included any changes in medications. Actually, the results of the CTA were blinded. There were nothing to do because nobody knew what to do. These other studies were ongoing, and this was a puzzling effect. And it became only more puzzling by looking at it. Not only did it grow unexpectedly and uncomfortably, but it also fluctuated on its own. It's fascinating.
Yeah. I have one other question, and I don't want to take up everything, but could I ask just one other question?
Mm-hmm.
It is so interesting that the increased risk of bleeding in this really frail population is associated with mortality, which isn't surprising. But before we would do any kind of aortic valve intervention, there is a higher risk of bleeding to begin with Heide syndrome, with AVMs. Has anybody really studied to see if most of the bleeding that is coming from the GI is still related to AVMs, or is it related to the TAT, oral anticoagulants? Has anybody been able to tease that out?
Well, a systematic GI risk study hasn't been done. But I can tell you that in our studies, we looked and we found that a lot of patients, actually 2/3 of the Envisage study, the latest one, were on PPI. So based on that, very difficult to postulate that upper GI bleed was a major component. So maybe that's why one can say that perhaps these agents may have something to do with a complication and later mortalities, perhaps, is because if you bleed from a source of the small bowel or something, then how do you control or even diagnose it? It may be very difficult. The other aspect that is the age factor. Aortic valve disease is not just people with AVM. It's not just people who have a lot of plaque in the aorta. It's also very old people. And the bioavailability of any drug could be very different in the 80s and 90s years of age than in the classic, I would say, AFib trials, which are patients in their 60s. And the drugs or the doses of the drugs were found to work fine in the 60s, in studies, I should say, that included patients in their 60s, well, may not be exactly accurate in patients in their 80s and 90s. And it's a new era now. Before we weren't considering, I would say anyone in cardiology was considering to go and say, oh, you know what, it's now, early 2000s or 1990s. Oh, how would I really treat the patients over age 80? I'm not sure that was even in the agenda. So we're doing studies just on what we thought is the pertinent or the relevant age group that has atrial fibrillation or stroke risk and whatever. Turns out, with all the great advances in all of medicine, now we're treating patients with far greater age. And I'm not sure we're up to speed about that in many aspects, in several aspects. And perhaps now we're uncovering a new thing. This can be a new thing that we'll in general uncover. So perhaps we need to be a little bit more careful with dosage. Perhaps we need to adjust better. And indeed, in a research, we saw that these untoward events of the bleeding wasn't as apparent when the dosage was reduced to 30 milligrams. So we're doing, as we speak, we're doing this time, we're going to have more papers about this in European Society of Cardiology 2023, as we try to further mine exactly what it means to reduce the dose. Should we be reducing the dose to more people? Could that affect in some ways? I think it's very intriguing.
Dr. Angus, this is Ashish. Thank you for a wonderful presentation. It was really enlightening. And so, from your key takeaways, the thing is, if we encounter one of these situations in clinical practice, obviously it's different if you encounter it in the setting of somebody who's had a clinical event like a stroke or something. There you might feel somewhat more compelled. But ordinarily, if you encounter it in clinical practice right now, I guess the key takeaway from your presentation is do nothing, just waitful watching for most part, unless there's a clinical event, or do you? And the second question to it is the location of these particular clots, whether these are TAVI valves or even surgical valves like you showed. You think it's got something to do with the interaction of the stent-based strut? Because it's right at the base where there are eddy currents and things like that. So whether this is not truly the more friable clot that's more likely to break, and whether it is actually a more fibrillous, organized clot, that's why it doesn't matter whether we anticoagulate or not, to the degree that it will not break and cause those events.
Right. I mean, first of all, the location has, I think, a lot to do with the way the blood flows or backflows, if you want, towards the valves during the diastole. And that may create some special conditions right at the bottom of the cusp, essentially. That's where it kind of starts. These days, the most common reason to find, and I get calls about that every other week here and there, is because people find that the gradient has jumped, which is a minority, but I think we only hear about a minority now. Because the scenario goes as follows. There's a little jump, the gradient goes maybe 20s, then they do a CT or a TE, which is indicated. I have to tell you, sometimes the gradient jumps and it's just the heart getting better, or there's the early acceleration of the systole and not really a valve gradient. But let's say now we do find that there's a clot. But sometimes you find there's no clot. That's what I was just explaining also before. Now we find a clot. Then if you find a clot that has a gradient, Then you're talking about now the beginning of a significant valve deterioration. So from that aspect, I would say you need to anticoagulate for some time. And how do I anticoagulate? I think even low dose can do the trick. And again, you re-image. You're obliged to re-image, because what we saw is that the problems arise with a long term. So you want to re-image and say, okay, well, I dissolved it. I don't want to continue it anymore after a few months, because that's another way to mitigate the risk. I told you before, a way to mitigate the risk if you reduce a dose. Another way to mitigate the risk of bleeding is you shorten the duration. Clearly, the study showed that these adverse outcomes emerged long time later. It wasn't an immediate adverse outcome. So to have it shorter, particularly for a good reason, you can dissolve it, and then your image is gone. Well, then you stop. And then you image again in 6 months and see, well, is it durable? Perhaps was facilitated early on by incomplete endothelialization, and now I dissolved it. By now it's endothelialized. Well, maybe it doesn't recur again. And you can sort of follow like that. So before we don't have any specific, I would say, study, I would follow this pathophysiology-driven imaging and dissolving, and then stopping the anticoagulation after some time.
That's what I think we're doing, but the reason to ask you is we seem like we're flying blind a little bit. It's all kind of, you think that's the way to do it because the data still, you don't have much, but what you mentioned is a very, very common scenario that we all tend to face.
Right. I think we got to image, and we got to image and re-image, so to speak. It's just difficult to say, okay, well, I mean, I know of extreme cases who had a very significant gradient that completely went away after 3-4 months of anticoagulation, and it never recurred. So I was surprised by finding that how high those gradients were, and I was very pleased to receive later on that the result was very fruitful, just with some warfarin they gave. That was a specific case was in Europe. That was so it kind of have to go based on pathophysiology and not based on any prospective study on that. Durability is a very important aspect, and I think we're going to see more studies about that and more data towards coming up that way. It has never been studied, and not even in surgical valves. But it matters a lot because, as again, our populations now live longer. We're going to be faced with the durability question, the potentially repeat valve procedure later on. So it is something very important to think about.
George, this is Sabino from Cooperman Barnabas. We've been following the guideline or illustration that's in the article you wrote with Dr. Capodanno, namely a post-TAVR indication for anticoagulation. We continue anticoagulation, no indication, it's single antiplatelet therapy. And the third group is the people who had a recent stent where they get dual therapy, for example, Plavix and Eliquis.
Right.
Is this what you're doing currently clinically? And the second question is, do you foresee a population that may require, let's say, almost lifetime anticoagulation? For example, TAV and TAV, or TAV and surgical valve, or TAV and mitral position, which is a whole different population, hasn't been well studied, but it seems like they're at great risk.
Yeah, well, the mitral position is clearly something I have to worry about and consider the longer-term anticoagulation, because the risks of the left atrial thrombosis are very different. The hemodynamics are different. So I see that more. The valve-in-valve, I have mixed feelings about it. I think it's good to think about it, maybe for a term, maybe a few months, and then we can reassess the patient's bleeding and risks in general. I think something that we need to underestimate, I think, when we in these discussions, is that the clinical practice can't be dominated by whatever anyone says at the time of TAVR. upon discharge. It's just so many things happen. These patients are older, things happen. Whatever we say is just valid until the next appointment. And at the next appointment, you need to have a serious reevaluation of the ongoing risks and benefits of these patients. So I feel uncomfortable to say, okay, I commit someone to long-term just because I say so after the valve. I'm commit them to that until I see them again. And as far as what we do in Mount Sinai, we no longer use a clopidogrel loading because that's been associated with a lot of situations of bleeding and vascular complications. But we do use a clopidogrel upon discharge for 3 months as the guidelines indicate in the United States. And again, no study actually had found anything wrong with that because every study started with a loading dose of clopidogrel pre-procedure, blah, blah, blah. So there was a lot of events during the TAVI itself dominated by the loading dose. We don't do that, and we just prescribe it upon discharge as part of the discharge medications. That lasts for about 3 months and contingently for 6 months if needed.
And that's single agent, not, or is that with aspirin? Just single agent?
With aspirin. And sometimes I mitigate that to clopidogrel alone if we feel that there's some bleeding risks and all that. Let's not forget that in the very old studies, the clopidogrel monotherapy was superior to aspirin monotherapy as far as the bleeding risks, particularly the GI bleeding risks.
Thank
you. Hey, Dr. Dangas, this is Ankur. How are you doing?
No, very well, Ankur. Nice
to see you. I have 3 questions for you. So I know, thanks for doing Galileo. That is like the landmark pioneer trial really to understand antithrombotic therapy for TAVR. But unfortunately, it showed increased mortality. Now, Atlantic, the cohort without any indication for oral anticoagulation also showed increased mortality.
Yeah.
Then ADAPT TAVR, which was the edoxaban trial, without the indication for oral anticoagulation, also had a trend towards increased mortality with anticoagulation. So first question is, do you think there is something else going on in terms of this anticoagulation causing increasing mortality in elderly TAVR patients? That's one. And second, based on this data, the ACC kind of backed off. So current valve guidelines actually do not mention NOAC if you have AFib onset within 3 months of TAVR. Using anticoagulation with vitamin K is a 2-way indication. So if somebody develops AFib post-TAVR, what are you doing in terms of what is the standard of care in your mind, considering most people prefer NOACs? And then third question, which kind of ties in to the question you just answered, is the valve-in-valve question, especially the valve-in-valve in small valves, 23 millimeters or smaller. We tend to find these people, even after cracking, they have high gradients, even right after the procedure. I mean, empirically, we have at Robert Wood have given them 3 months of low-dose Eliquis, and it's all empirical. At least to my mind, looks like it helps the gradient or worsening gradient at 1 year. There is no real objective way to measure it in a randomized fashion. But what are your thoughts in valve-in-valve in small valves?
Yeah, well, let me start. If I forget any of the questions, remind me, please. So starting by what happens, let me add one more study that has gone a little unnoticed, that the NOACs lost against warfarin is the rheumatic heart disease valve, AFib. There was no artificial valve, but rheumatic heart disease. Rheumatic heart, not TAVI, I should say, but rheumatic heart disease. That did not go so well. So it seems to be that the valve populations have something, perhaps in relation to what I said before about the AVMs and all that, that the non-reversible anticoagulants may have a little bit of a disadvantage. Nobody can understand that. Perhaps it is when you go into the valve population, perhaps it is a combination, or perhaps the adjustment of dosage is not very appropriate for ages over 75. And that's what we're seeing when you study this population. Is the age thing, or is it the valve thing? And the valve thing may be related to the small bowel source of bleeding, and that may not be very well tolerated. So that's part one. The small valves, well, I always take a gradient after the procedure. Hemodynamic. Pigtail. 2 pigtails, one in the LV, one in the aorta. And at the same time, I document what is the gradient by the echo. And I always note this difference. And very often you see that the acceleration of the blood from an hypertrophied LV that is also small is significant. And at that time, I know that the gradient is 0 or nearly 0 hemodynamically. So from then on, no matter gradient the person develops, you subtract that, or I subtract that, because I already know the patient had a gradient of, tell me, 12 or something, 11, and I'm finding 1. So I know it's plus 10, just because there is some acceleration factor here that creates a peak instantaneous gradient with not a lot of VTI. So that way, I would say I rationalize a little bit those readings of high velocities after procedure, with the knowledge that the gradient just doesn't go up in 1 minute or 1 day, and it must be that we're measuring something slightly different that we need to control and account for. And I think that's a hint that I would say I advise more widespread use. And quite frankly, it makes no sense why we don't do it. We just have the wire in there, we can just put the pigtail and take an accurate measurement, versus we just, if you don't do that, you just save, I don't know, 30 seconds. It can't be more than that to exchange the pigtail over there. So by wasting 30 seconds, I obtain some useful information that helps me, allows me to scratch less my head when we have these problems later on. I think I missed the middle question.
It's like a new onset AFib in somebody right after TAVR.
Okay, good. No onset AFib after TAVR. I think, listen, the classic teaching is you got to go with warfarin. Now, if you say that the patient doesn't like to go to warfarin, or if the patient is going to have a lay NR, or they cannot measure warfarin and all that, then you can utilize a closed second that may be any of these well-adjusted medications. Could it be edoxaban 30 milligrams? Could it be the apixaban as adjusted? Whatever. But you give a choice, and if the people don't want the choice, well, go to your next best.
Because I think ACC makes it a point in their guidelines. If AFib is less than 3 months, they took the NOACs away from that diagram and their guidelines.
Well, there's no study. Why would they keep them there?
I think they cite Galileo.
Just because people like it, just because it's available, doesn't mean it makes the guidelines.
Right.
That's what I'm saying.
Dr. Dang, Bruce Hank, if you suspect partial leaflet thrombosis, say for a high gradient post-TAVR, do you have any preference in terms of TE or CT to diagnose the leaflet thrombosis?
Yeah, definitely CT is the CT video is the best option. If the patient has renal failure, we can consider the transesophageal echo. But given that it is a more invasive test, quite frankly, and not as clear the image, no need to do that in everyone, only in patients with significant renal failure.
Thank you.
Well, let me see. I see the chat. I see any questions in the chat. No, I think we addressed the questions in the chat.
If there are no other questions, could I jump in and ask one other question?
Go right ahead.
So, there has been a lot of data that has come out showing that even in the descending aorta, if there is a thrombosis, it is thought to be associated with a higher risk of stroke. Given that most of our TAVR patients are in their late 80s, 90s, that potentially could be a huge contributor to the strokes as well. In that population, obviously, anticoagulation, oral anticoagulants have been shown to increase the risk of hemorrhagic stroke to a higher extent. And also there is a slight increase in the embolic stroke in this population. It is so difficult to wrap my head around how we are going to be treating our patients with the right kind of regimen. Do we have to go with a lower INR? Do we, any ideas as to how you're doing it in the very elderly?
Yes, well, let me say that the same patients who have atheroma in the descending aorta, the same patients may have atheroma in the arch, or they have atheroma in the brain. They have a lot of atherosclerotic disease. The more we see the CTAs, we find that people have also atheromas in the brain arteries. Could this mean that during a hypotensive episode, we may have demand ischemia in certain portions of the brain, and then we have some, and then we may have some CVA or other? It may be. But specifically about the microbleeding, let me say something. I didn't want to go too much into the detail of that because that's a lot of slides about neuroimaging, etc. But our study, Galileo had a sub-study that did MRI in a fraction of patients for many MRIs, before, after, and at 30 days. 90 days, I should say, before, after 90 days, 3 MRIs. And we looked and see perhaps there might have been microbleeds in one group versus another, because one of our group was rivaroxaban 10 milligrams, the other one was antiplatelet. There was some mortality later on. Could it be that we were more microbleeds? Attractive theory, we didn't find many microbleeds. So it remains a theory, but with the 50, 40 or so patients we had in the MRI, these 3 MRIs per patient, we could not find many or microbleeds, and we could not find any microbleed discrepancy between the 2 groups. I find that interesting. I hear there is a French group about to publish this year a study on microbleeds, and I'd like to know more about that. What do I do practically? If there's no indication for oral anticoagulation, I may just give them clopidogrel. That has lower risk of complications than oral anticoagulation, and it may be sufficient for the widespread atheroma, if you will. More like, I would say, the Capri trial paradigm of 25 years ago that treated patients with atherothrombosis, aspirin versus clopidogrel. Clopidogrel was a little bit better. The study at that time was criticized why each one of the sub-studies wasn't significant, something we wouldn't do now. The overall study was positive, and then it was criticized. Why is it that the brain atheroma patients didn't have any difference in the peripheral atheroma patients and the coronary atheroma patients? And each specialty wanted their own results, let's say. But I do believe now we have a little bit better understanding of what's happening with these patients. The atheroma may be sufficiently treated by clopidogrel more so than aspirin, and that may be a more favorable profile in the patients who are scoring as high bleeding risks at over 75 is a criteria.
Dr. Dangus, one final question. Is there any scenario in which you use a vitamin K antagonist versus a NOAC or a DOAC in patients with prosthetic valves, specifically TAVR type valves?
Yeah, if they have atrial fibrillation, we have to consider that as a top choice, and we recommend it. I can tell you that many clinical cardiologists and many families opt out.
Right.
But I think it's something we have to consider. The surgeons like it a lot. Why? Because after surgery, they start the warfarin. It slowly gains activity over 7 to 10 days. And they essentially like this delayed gain of activity in order to avert many bleeding complications. So in the end of the day, that's a clinical criteria. They may not be that wrong. We didn't find anything, even in our studies, when we compared with warfarin, we didn't find we're doing anything better these first few days. One of let's say when we looked at the 3-day stroke or whatever event, not much activity. So by the hype of like wanting to anticoagulate patients faster, I think it's treating doctors' brain more than anything else. We didn't really find that much activity happening the first few days. I agree, it's possible, and I'm talking now first few days after the initiation of the first few days of hospital discharge. This does not necessarily mean the first few days after TAVI or the first days after surgery, because those days we're not starting any patient anyhow. This is treated the way in hospital management treated, and obviously that's a high-risk group and high-risk time frame, but it's not a time frame we can do anything about when, the groins are open and the chests are open and all that. It's just a little difficult and very hypothetical to say, oh, I wish I had these patients on anything non-reversible. And we saw the Post-TAVR results when this investigator started the drug before the procedure. They had 10 and 20% of major bleeding on day one. That's a lot of bleeding, no question about that.
Dr. Dangus, how about envisage AFib trial, which was edoxaban versus Coumadin, was non-inferior?
Non-inferior. Yeah, I think that's actually...
That may be the one...
Yeah,
that may be the only clinical trial.
Well, I personally try to employ, well, I was a PI of the study, I might as well believe the results, no? I try to employ the edoxaban 30 milligrams as much as possible, as far as the adjustments needed, and be very clear that when the adjustment is needed to do so. And I think that is out of all the edoxaban results in this study, the 30 milligram subgroup seemed to be the one that had the least side effects.
And even for, I think, surgical valve, there was this trial for mitral river that NOACs may be equivalent to Coumadin.
Well, I mean, I don't know. I mean, if you really want to go and use a word equivalent, they really have to do much larger trials than those studied thus far. I'm not sure anything is equivalent. We just have hints here and there, and particularly, I show you in the antiplatelet, Arthur had 100 patients and per group, and the Post-TAVI had, I don't know, a few hundred patients. I mean, in order to solve the problem, you need to have 3,000 patients in order to be able to show what I proved and what we didn't prove anything. We just feel better that nothing too terrible is happening, and we have a series of preliminary, I would say, pilot studies indicate one way that perhaps a simplified regimen is better, is safer, it just is okay. And everybody likes to simplify their life and simplify their regimens, and we just go with it. And that's a reality. But this doesn't mean we know, this doesn't mean we've proven, this doesn't mean anything is equivalent with anything else. We just feel like we're sort of okay if we simplify the regimen.
Dr. Dangus, I would like to thank you very much. Nothing like hearing from the master at this. It has been really educational, and thank you so much for this wonderful presentation and discussion.
And I would like to thank you for organizing this great session and everyone for attending. Thank you. Best regards to the rest of the faculty who didn't speak up or I haven't noticed their names up on the board that I see.
Thank you. Have a good night.
So long.
Have a
Bye-bye.
great night.